it's my honor to chair this session. And first up, I'm not going to do a very long introduction because all of these speakers really need no introduction. Come on up. And first up is Dr. Natasha Rajah, who I may or may not have said her name completely properly, was at McGill University, but now we have recruited her to Toronto. Unfortunately, not CAMH, and she's at Toronto Metropolitan University, but I guess we can spread the joy around a little bit, right? So thank you, Natasha. Take it away.
Thank you. So my talk's going to be a bit of a switch from the previous talks. So first I want to say thank you to Lisa and everyone at womenmind and CAMH for organizing this exciting conference and inviting me. I've been learning a lot and taking lots of notes. It's been really thrilling. So today I'm going to talk to you about some ongoing research in my lab, the BAM project, or the Brain Health and Midlife and Menopause Study. And I'm going to focus on some of our early current results. But before I start, I always like to, this has been going on since 2017. Is it this I'm supposed to use? Oh, bam. All right. So I first want to acknowledge, this is a study that's been going on since 2017. So I want to first acknowledge the team of trainees and postdocs and collaborators that have helped conduct this study to date, and my collaborators at the bottom, and also the funding agencies. So we've been receiving continued funding from CIHR's Institute of Aging and Gender and Health to conduct this project. So I want to give you a bit of a background about myself. So I'm a cognitive neuroscientist that studies episodic memory function. So episodic memory refers to our ability to encode and remember past personal experiences in rich contextual detail. And since my PhD, I've been studying how does episodic memory and its neural correlates differ across the adult lifespan using task-based fMRI. And what we've found today is that when you look at extreme age groups, when you look at young adults versus older adults, what we see is that there's specific deficits in certain types of tasks that tap into episodic memory, particularly tasks that tap into spatial abilities and temporal abilities. So our ability to remember the spatial location in which you saw a face or the temporal order in which you encountered a series of faces. That tends to show a specific deficit at aging. And what we noted in our lab was that there's been a lot of research on this, like we did this 15 years ago almost now, right? So there's a lot of research looking at extreme age groups, but very little was known about midlife and looking at episodic memory, particularly for this contextual, spatial and temporal contextual detail across the adult lifespan. And so in collaboration with my former PhD student, Lizzie Yankudovic, and collaborators in this room, we conducted the Montreal Adult Lifespan Study, in which we recruited 128 adults between the ages of 19 and 79 to come into our lab and perform a spatial context and temporal context memory for faces while they underwent imaging, so task-based fMRI. And what we found was the typical, as expected, linear decline in both spatial and temporal context memory across the adult lifespan. But then we decided to look at age groups. And what we found was that compared to young adults, middle-aged adults and older adults performed significantly worse on this type of episodic memory task, so spatial and temporal context memory tasks. And interestingly, the middle-aged adults didn't perform that differently to older adults, meaning that this type of memory seems to decline at midlife. So it's a sensitive task for detecting early changes in episodic memory. Now, at that same time, we were also interested in sex differences and looking at how age-affected memory function and brain function in males and females. And the reason we became interested in this was at that time, literature was emerging that Alzheimer's disease might have a higher prevalence in females, so 2/3 of cases of Alzheimer's disease are diagnosed in females. And episodic memory decline is one of the earliest signs of Alzheimer's disease. And in addition to that, there's emerging literature showing that episodic memory decline and the neural correlates of episodic memory decline might start to show differences in Alzheimer's risk patients in their midlife. So here we had a task that was sensitive to midlife and episodic memory function. So we want to look at whether or not in this healthy cohort, so these are adults that do not have risk factors for Alzheimer's disease. We actually screened out adults that had a family history of Alzheimer's disease. We want to see if there was sex differences in the effect of age and memory function and in memory-related brain function. And so this was a project led by a former PhD student who's in the audience here, Savanya Subramaniapillai, where she asked, are there sex differences in the effect of age on memory and related brain function? Now, historically, in the cognitive neuroscience of aging, no one really looked at sex differences in the effect of age on memory. And that's because behaviorally, we rarely see it. So behaviorally, we see similar patterns of decline in females and males across the adult lifespan in memory function. However, as Lisa has shown in previous talks to my lab and to others, just because there's no sex differences in the behavior, it doesn't mean that there aren't sex differences in the underlying neural mechanisms. And so we took the fMRI data that we collected in this study, and we looked to see if whether or not there were sex differences in the effect of age on the neural correlates of memory. Behaviorally, there aren't any. And we identified a pattern of activity that was specific to females. So with advanced age, females show increased activation in frontal parietal areas and in midline cortical regions during memory encoding, and decreased activation in these same regions at retrieval. Now, when we looked at females, we also saw that that increased activation in encoding supported memory for a harder version of our spatial memory task. And so when we didn't disaggregate our data by sex, we did not see this effect. We saw the same brain pattern of activation, but no relationship to behavior. Now, when you look at males in this data set, this pattern is specific to females. And in this sample, what we did is we matched our males and females on age and on education. So this is not because one group is older than the other or one is more educated than the other. This seems to be a female-specific pattern of age-related increases in activation and encoding and decreases in activation at retrieval. And so what we thought was, okay, so midlife, is a critical period in episodic memory function. There seem to be sex differences in the neural correlates of age-related episodic memory decline. Perhaps we should focus on midlife and look at sex differences. Now, another thing that I noticed at that same time, and many others in the field were noticing, is our samples are not representative of who is in our population and who is aging. So where's my mom? Where am I in this data? Most of our samples are of white, highly educated adults. And so this is my family. We're very diverse. We have people from multiple different backgrounds in our family, and we just don't see each other in our data, in these data sets that are out there. So the Montreal Adult Lifespan Study really taught me many lessons that I then carried forward to the Brain Health and Midlife and Menopause Study. First, it taught us that there are sex differences in the effect of age on the neural correlates of episodic memory. These differences in behavior emerge at midlife, so age-related declines actually are occurring much earlier than we knew. And then the cognitive neuroscience of aging has not been representative. And so how do we fix this? So that's what motivated this study. And this is a study that has many collaborators who are in this room right now. The Brain Health and Midlife and Menopause Study, BAM, in diverse individuals. So this is the goal of this study, to really diversify our cognitive neuroscience of aging and understand women's health at the same time. So BAM is aimed at addressing four main questions. How does biological sex and menopause status affect episodic memory for spatial context and midlife? How does biological sex and menopause status affect the neural correlates of spatial context memory at midlife? Do any of the observed effects interact with known risk factors for Alzheimer's disease and other dementias, such as the ApoE genotype, vascular factors, et cetera? And then something that has been already talked about today in the earlier presentation is, how do lifestyle factors and the social determinants of health interact with these variables to result in the individual's experience of aging? And so these are the four questions that BAM aims to address. It's an ongoing study, as I said, and you need huge, huge sample sizes to address these questions. And that's why I'm looking forward to collaborating with many of you in this audience to try and combine our data sets. But what I'm going to show to you today is just data from the first two questions. So one thing about BAM, as I mentioned, is we have a very ambitious recruitment plan. So we aim to get up to 600 or more middle-aged adults into the sample. We want to focus on the ethnocultural diversity of Canada, which is represented here. This is from StatsCan. I literally downloaded it and then put it on a bar graph for you. So most of Canadians do not identify as visible minorities. The next group is South Asians, followed by Chinese, Black, Arabs, etc. So we want to represent this level of diversity in our samples. And in BAM, what we do to do that is we first have an online enrollment. So you enroll in line, you fill out a bunch of medical questionnaires, you fill out a lot of reproductive questionnaires. So this is Emily Jacobs' contribution. She really helped us kind of hone in on trying to understand how do we get at reproductive health in females. So they fill in all of this online, and then we include individuals that meet our very bare minimum criteria. So very bare minimum. So if you're on SSRIs, you could participate in this study. If you have low education and you didn't go to university, please come and participate in our study. And so we're really trying to be as inclusive as possible in our recruitment. So those are the individuals that we could then reach and bring in. We come in for a session one, where we do a series of nice neuropsychological assessments to look at executive function and verbal memory. And there's issues around the verbal memory. And lifestyle and health questionnaires. So we really are trying to get a deep phenotyping of the individuals that come into our study, right? To understand who they are, their childhood adversity, what are their parents' income levels, where did they grow up, are they immigrants? So really trying to understand who these individuals are to put the personal back into the science. And so in addition to that, then we use the STRAW 10 questionnaire in addition to blood sampling to determine whether or not they're pre, peri, or post-menopausal. And so they're donating blood and we bank the blood. So we have a blood bank that we use then to look at protein levels, hormone levels, and markers. And they also participate in a mock scanning. I really hope everyone does this with your participants for cognitive neuroscience. You can learn a lot about an individual without the MRI on, just to make sure that they're not claustrophobic, they could tolerate the task, and they're okay with lying down and listening to instructions. And so once they pass all of these kind of hoops, they get called in for a second MRI session, where they again give us blood donations so we could link their hormonal status and where they are in their cycle to their scan. And then they have a T1 weighted typical MP range to look at cortical thickness and hippocampal volumes, an ultra high resolution T2 weighted MRI to look at hippocampal subfields. Then we do a resting state fMRI to look at intrinsic connectivity of the brain, followed by, I'm a task fMRI person. So there's a task for episodic memory in this battery, and then a diffusion weighted image to look at white matter structural connectivity. I'm not going to go too much into detail. That's a picture of my daughter when she was a baby. But the task fMRI is a more complicated version of our spatial episodic memory task. And the reason we honed on this is we've already heard about how important spatial memory is, how sensitive spatial memory is for detecting early memory decline, and particularly in individuals at risk for Alzheimer's disease. So people are asked to memorize a face in one of 4 quadrants. They are either asked to memorize 6 faces or 12 faces, so we can look at performance effects within subject. And then they take a break. They tell us, how well do you think you did? Then they do a retrieval task. It's a very complicated retrieval task, but we have the response mapping there on the screen. And then they're asked to rate how well they did. And so this is our recruitment to date. And what I want you to see is what we start with and what we end up with in the scanner, because this is the reality of what most cognitive neuroscience is. And I always say we could drop all the neuropsych, we could drop all the questionnaires and just see if they could do the MRI. And that's our screening. Because if you could do MRI, you're pretty healthy to begin with. But we started with 17, almost 1,800 individuals that signed up online. 1,293 were excluded for health reasons. So there's a lot of sick people wanting to get care that can't get care because they're either, they have a strong psychiatric diagnosis, they have metal in their body, so all sorts of things that exclude them from MRI. And then we brought 481 into visit 1, and 203 were excluded because sometimes we just didn't know what menopausal status they were in at that time, or they had other undiagnosed conditions. that we then had to, follow up with their doctor. And of the 481, we have scanned to date 278. 20 have not been analyzed yet, like literally scanned those last 20 in the last month. So this is the ethnic distribution of our sample to date. Not great, but kind of following Canada's outline. Like it's not 100% white, right? 78% white. So we're trying hard to get that ethnic diversity. And this was conducted in Montreal, when I was at McGill. I recently moved to Toronto Metropolitan University. It is a much more diverse neighborhood that I'm in, and that's kind of the motivation. One of the motivations was to increase the diversity of the sample of BAM. And so just a bit of information of who we have so far. So we have quite a lot of young females, young males. We do have middle-aged males as well. And then pre, peri, post, and we still have some indeterminates there. So I'm running out of time, so I'm gonna whip through. Behaviorally, my postdoc, Ricky Lissaman, has been looking at sex differences in memory performance. And what we see at midlife, so this is adults between the age of 40 and 60, we only see age-related declines in the females. My other postdoc, Annelise Laplume, then used segmented regression. We're not going to look at the menopausal status. We're just going to look at when and if there's an inflection point at which memory decline starts. And what we saw was only in females, there's an inflection point for memory for spatial context or source memory. And it occurs roughly around the time that menopause on average occurs. And this is spontaneous menopause we're talking about. There's many menopauses. This is spontaneous menopause. And then when we do put in that information of menopause status, we see that it is indeed the postmenopausal females that are driving this effect. Now, age and endocrinological aging, chronological, endocrinological aging, they're correlated. So we look at both of them together, and we see that using partial least squares analysis, that both age and menopause status load with memory performance. However, in the postmenopausal females, that's where you see the accelerated age effect, right? So aging affecting memory decline to a greater degree. We have neuroimaging data from this cohort. So we did a quick analysis using partial least squares multivariate technique to look at how age and performance mapped on to brain activation during spatial and context encoding and retrieval. And this is a very complicated picture. And so here you see bar graphs where you look at age and its correlation to the pattern of activity here, performance on how well they did on the source task, and then how well they did in recognition memory. And what you see is that only in premenopausal females do you see this, which in the cognitive neuroscience is pretty typical, is reactivation. So areas that they engage to successfully encode information and encoding are re-engaged at retrieval. This is apparent in premenopausal females that are doing well in this task, not in postmenopausal females. However, in postmenopausal females, we see greater activation in medial temporal lobe regions like posterior perihippocampal gyrus and ventral visual cortex that supports memory for spatial context, but decreases as a function of age. So the reason that these postmenopausal females are showing this decline in memory performance seems to be related to medial temporal lobe and ventral visual systems declining in their activation as a function of age at postmenopause. So I'm wrapping up. See, I was on time. So what we can conclude is that menopause seems to accelerate age effects and episodic memory at midlife and alters brain function in the episodic memory networks. And so there's a negative effect of advanced chronological age on memory performance at midlife, but it's most evident in postmenopausal females. We did not see this in males, by the way. So males are flat in midlife. Menopause status directly affected the direction of age and performance-related correlations in brain activity. And critically, episodic memory abilities in middle-aged females may rely on distinct brain systems at pre- and post-menopause. So the brain is rewiring itself to perform these tasks, but that rewiring seems to decline with age. Now, one thing I do want to highlight is menopause is natural. This is not, I don't want to pathologize menopause. All females with ovaries menopause, and not all females show this decline, right? So there's a lot of variance in our pattern. As our sample increases, we should start getting at that variance, try and understand why do some females show this decline to a greater extent than others? And what are the factors that contribute to brain resilience and reserve in these females so we could help those that are showing decline? So thanks.
We have time for a couple of questions, short questions. Dr. Clark and Inger, you guys are the first to respond. Okay.
Well, first of all, thank you so much for your talk and the work that you're doing. We definitely don't have enough on menopause. And I have so many patients that are often in need of just understanding, like, oh, okay, this is normal. This is what happens. So thank you. I also wanted to just add a comment on the equity data or population data. I think it'd be helpful when, first of all, for you to get larger samples. I think if you can, I know that's hard, easier said than done. But I think also what we do not see enough in the research when it's published is what's the breakdown of those people who didn't, qualify or, decline to participate, which is very informative too, as we start to think about, well, how do, is it that we're losing them to follow up, or they withdraw, or they just never participate, or they never were recruited in the first place? So I if you could, I look forward to seeing that data. And then I would just say, as I said in my talk, we have to be careful to not, even though it follows the population data, to not use those small numbers to make conclusions. So
Yes.
that's all.
No, I totally agree. And that's why we look at social determinants of health. We do not ever intend to group individuals or look at group differences. That's something that the study is not even aimed at doing. We want to look at continuous variables that track risk factors. And we do have all that data that you're asking for. And that's something, we're trying to work. How do you publish this data, right? So people that aren't interested in participating. So we have all what you want to know, we have it. Let us know where we could put that data so people know.
Process of publishing a article where it's looking at Black and white specifically, and the reviewers asked for that data. And we didn't have it anymore because it was a secondary analysis. Okay. And they were like, so, but who withdrew and who, we don't know anymore. So I think as things are changing, people are becoming more interested in that. And it could be a part of kind of the final write-up.
Thank you.
Is this? It's on. So super impressed by the size and the depth of the studies that you're running here in Canada. Super interesting. But I'm a gynecologist, so my question is pretty obvious. Would estrogen resurrect any of the changes that you see after menopause?
So we are collecting that data. We allow everyone into our study. So some of these females are on HRTs, some of them on oral contraceptives. We have a rich data sets of their reproductive health, parity, when they went on certain hormonal treatments and how long they were on them. So we could answer that, but we need the samples. Like I'm not going to dive into writing a paper on an N of 20. Like it's not good. We have it. We're collecting it. Yes.
Thank you so much, Natasha. Next, I'm calling upon Dr. Kristen Zuloaga from Albany Medical College. Did I get it right? Yes. Kristen will be talking about vascular, I bet, factors as well as menopause. And without further ado, take it away.
So super happy to be here. First of all, thank you so much for the invitation, Lisa. This has all been so amazing. I love hearing everyone's talks and getting to interact with everyone. And Natasha's work is amazing. And I think my work is all in animal models. So we're going to go back to animal models. We've been going back and forth all day. But I think that a lot of the work that we're doing in our mouse models is really going to support everything that she just told you about is so important and answer maybe some of these questions. So I don't really have any disclosures, just funding that I have, nothing conflicting. So one of the things that I think is really interesting when we're thinking about dementia, this is a disease of aging, and we know that chronological age is the greatest risk factor for dementia. And as this whole session is about, the role of endocrine aging is less well studied. And so I think it's something that's really important. About 2/3 of those with dementia are women. So as we've heard so much throughout the day that, you know, for example, with anxiety and depression, that it's much more common in women, the same thing with dementia. And it's not just because they have a longer lifespan that does explain some of it, but one of the other things that we and others in the field think of is that maybe there is either exposure to more risk factors, different risk factors, or maybe their reaction to those risk factors is different. And so this is something that we're interested in looking at in our lab using animal models. So what are the consequences of endocrine aging in women and those with ovaries? So normally we think about this loss of estrogen, and there's been studies looking at how this endocrine transition affects the brain. And so one of the things that occurs is white matter loss. This is kind of interesting because white matter loss is also something that is very characteristic of vascular dementia, which is it's the second most common cause of dementia. And so this happens with women as they age. They also get a reduction in brain glucose metabolism as well. So this is work that Roberta Gritton's group and others have shown. If you go through menopause earlier, you're at increased dementia risk. And then one thing I think is really interesting is that menopause is also going to increase your risk of other dementia risk factors. And so one of the main ones that we focus on in our lab is different metabolic diseases. So things like obesity, prediabetes, type 2 diabetes. These are going to then all increase your risk of later developing dementia, and their risk increases after menopause. And how much of an increased risk for dementia that's going to be depends on what type of dementia you're talking about. So if it's Alzheimer's disease, it's about a 2-fold increased risk. For vascular dementia, about a 5-fold increased risk. And so I think this is also something that's very interesting. And so our lab is kind of looking at the intersection of a bunch of different dementia risk factors, which I'm not going to talk about all of them today. But one of them that we've been interested in is metabolic risk, which we heard a little bit about this earlier with Julia's talk about how the visceral adipose tissue correlates with brain changes. We've also done work, I'm not going to talk about it today, but looking at sex differences and how in midlife a high-fat diet affects cognitive function. And actually in the females, we see the more visceral fat they accumulate, the worse their spatial memory is, the more neuropathology they have. We don't see the same thing in the males. And so this is one thing that I think is very interesting. We also have more recently been looking at effects of stress, so chronic variable stress, which we've also been hearing about as well. But we just got that grant a year ago, so I'm not talking about that today, but maybe next time. But the main thing I want to talk about today is this interaction between sex-based risk factors and vascular risk factors. So looking at sex differences and effects of menopause and how these interact with vascular risk factors for dementia. So about 80% of those with Alzheimer's disease actually have underlying vascular pathology. So there's just a high comorbidity, which I think is underappreciated. And it's been shown through many different studies that this vascular pathology might be really important. So vascular risk factors, things like hypertension, obesity, diabetes, atherosclerosis, all these things are going to increase your risk for any form of dementia. And vascular dysfunction is one of the earliest pathologies that's observed in Alzheimer's disease. It often precedes the cognitive decline. So there's this large study, actually was done in Canada. So there we go. Over 7,000 human brain images. And they found that these vascular changes that they could see were some of the earliest and strongest predictors of dementia. So I think that this is an area that's very exciting. We've been doing some work very recently in our animal models of Alzheimer's disease and looking at changes in the endothelial cells in the vasculature, something called the endothelial translatome. So it's the the genes are actively being transcribed. And we see that in our animal models of Alzheimer's disease, even before they start to build up amyloid beta plaques in the brain. So before you see the traditional Alzheimer's disease pathology, we see a lot of genes change, over 7,000 genes that are changed in these animals. So this vascular pathology is kind of something that happens very early on. So you can have this vascular pathology in the context of Alzheimer's disease, as I mentioned, but also if you have this vascular pathology just on its own, this is the second leading cause of dementia, and it's known, it has a really long name. I apologize, I did not invent it. My program officer did, but it's vascular contributions to cognitive impairment and dementia, or VCID. And so this is the second leading cause of dementia, and this can be caused by a variety of different vascular pathologies. It makes it very hard to study because there's so many different flavors of it. But so it can be caused by a reduction in blood flow to the brain. So think if you have a carotid artery stenosis or occlusion, it can be caused by damage to the blood vessels within the brain. So if you have arterial sclerosis, if you have microbleeds, if you have microinfarcts, if you have a stroke, large infarct, and then also there is overlap between this vascular pathology and amyloid pathology, because amyloid beta protein can actually build up in the blood vessel wall and then cause microbleeds. So when you have this occur together, it's called multi-etiology dementia. Our lab also studies that, and we've done a lot of work looking at sex differences in that, but I don't have time to talk about all that today. But I want to focus right now on the VCID, or these vascular contributions to dementia, because that's what we know less about in terms of menopause. So as I mentioned, we do animal work. And so how we can model these vascular contributions to dementia in mice is we actually reduce blood flow to their brain. And we do this with a surgery. So we can go in and we can target one of the carotid arteries, and then we can actually occlude that artery and reduce blood flow to the brain. So I'm showing laser speckle images before and after that surgery. There's a large decrease in blood flow to the brain immediately after the surgery, but then long-term, it's about a 10 to 15% decrease in blood flow. So we're not causing a stroke, it's just a mild reduction. And why this is important for your brain is that the purpose of the blood flow is to bring oxygen and nutrients to all the cells in the brain that need it. And so if you are deprived of these things even a little bit over time, this then leads to cognitive impairment. And we're also very interested in menopause. And so we use a couple different models to model menopause in our lab, because there's many different types of menopause, as we're going to hear about more in just a moment. So in human natural menopause, as we've heard today, there's these huge, large fluctuations in hormone levels that occur during the perimenopausal phase, and then you go into a postmenopausal phase with low estrogen levels. And so in mice, we can simply remove the ovaries. This is a great surgical model. There's women that go through menopause due to surgical means because of reproductive cancers. And then we also heard earlier today, apparently it is the last line of defense for some treatments for depression, which that was something new that I learned today. So we use this model in our mice sometimes, and then sometimes if we want to be able to model that perimenopausal phase, we'll also use what's called an accelerated ovarian failure model. So we can give a ovarian toxin called VCD, and we inject the mice with this toxin for 20 days, and then it takes them about 3 months to then go into menopause. They go through a perimenopausal phase where they have these fluctuations in their hormone levels. Some labs have even measured hot flashes in these mice by measuring changes in their tail skin temperatures. And so one thing that we thought might be interesting to use this model in the context of vascular dementia, because when women go through menopause, it's been shown with MRI studies, the more hot flashes they have, the more of these white matter hyperintensities they have, white matter damage. And so that's a vascular dementia pathology. So we thought that would be interesting to look at. I'm not going to go over how we check to see if they're menopause, because Maria already did this for us earlier today, but we can check this with vaginal cytology to confirm that they do actually go into menopause, and then we can do histology of the ovaries to just confirm. So these are the two different models we work on, and in the first study I'm going to show you, we were using this accelerated ovarian failure model where we give this ovarian toxin. So my grad student, Olivia Gannon, at the time, she's graduated now. She's just graduated last year. She wanted to look at the effects of menopause on this vascular dementia model. And so she gave these injections of this ovarian toxin to cause the mice to go into accelerated ovarian failure. She waited until they were all menopausal, and then she did the surgery to reduce blood flow to the brain, or sham surgery. So if they're reducing blood flow to the brain, this is modeling the vascular dementia. And then we did behavior studying to look at, as we just learned about, episodic memory and spatial memory. So basically in these tests, the mice are placed into a box with two identical objects, and then we can replace one of the objects, and they will then want to spend more time with this new novel object if they remember they already seen the previous object, or we can have two objects that are the same, and we'll move one of them to a new location to be able to look at spatial memory. And so when Olivia did these studies, one of the first things that we found was just like when women go through menopause, their increased risk of having metabolic impairment, we did see that there was weight gain in our menopausal mice, which are shown in the purple bars. And so it didn't matter if we reduced blood flow to the brain or not, just if they were in the menopausal group, they did have this increase in body weight. They had increases in glucose intolerance, not shown here, and increases in visceral fat. We looked at their episodic memory. We wanted to see, again, in this test, we've replaced one of the objects with a new object. They should be spending more than half of their time with that new object. We found that the only group that was not showing a preference for this novel object and was significantly impaired were menopausal mice, where we reduced blood flow to the brain. I should also mention estrogen normally promotes blood flow, so it is normal for them to normally be protected from this from the females if they're premenopausal. We also looked at a white matter marker, so myelin basic protein. We found that this was reduced in the menopausal mice. This is similar to what is observed in humans where women have this white matter loss. And so we were excited about that. And then because we have this model where we give this toxin and they go to accelerated ovarian failure, there is some variation in how long it will take an individual mouse to go into menopause. So although our mice were all the same chronological age at the end of the study, they weren't all the same endocrine age. And so when we did correlations with how long they had been in menopause and their spatial memory, we found that the longer the mice had been in menopause, the worse their spatial memory was, which I thought was pretty cool. So overall, we found that menopause had these metabolic, cognitive, and neuropathology consequences in our model of vascular dementia. Now, we also thought that menopause was going to reduce cerebral blood flow because estrogen is a very potent vasodilator. And so we thought when you lost this, there would be a reduction in blood flow. However, we saw reduced blood flow in our mice where we gave them the surgery to reduce their blood flow as we expect, but we didn't see an effect of menopause on resting cerebral blood flow. I had a friend and he was doing similar studies, not with the vascular dementia model, but just in normal mice with the same accelerated ovarian failure menopause model. And he also found the same thing using the same technique. We're like, okay, neither one of us found anything, no changes in resting cerebral blood flow. So this is Paulo Perez, who's at University of Arizona. But his lab took it a step further. This is kind of their specialty, looking at something called neurovascular coupling, which is the basis for functional MRI. So when you have neurons that are activated, blood flow increases to that area. That's what you normally see on the MRI. But when you have a breakdown in basically the neurons being able to recruit more blood flow, this is called a loss of neurovascular coupling. With mice, you can give them a whisker stimulation to activate neurons and see if they increase blood flow to that area. And what he found is actually with the menopause model, they have this impairment neurovascular coupling. So they're not recruiting as much of this blood flow as they should be. So we thought this was really interesting. And we're now moving on to look at more vascular consequences in this model. And this is an area of ongoing research for our lab. It was asked earlier, would estrogen be beneficial if we were able to give this back? So I'm gonna now answer your question in mice. So not humans, but in mice. So I had my grad student, Abby Solinero, and my postdoc, Charlie Abiganum, who some of you know, wanted to look at cognitive effects of estrogen replacement. We decided to use a brain-specific estrogen prodrug because if you give systemic estrogen, this increases risks of various reproductive cancers, and so women might not want to take it for that reason. And so we wanted to look at something that was brain-specific. This is not a prodrug that, thank you. It's not a prodrug that we invented. This was developed by the ProChi lab in Texas. And this prodrug is very cool because it is kind of inactive in the periphery. And then when it goes to the brain, it gets converted to 17 beta estradiol. So it can activate all of the estrogen receptors. So they took mice, either young or middle-aged mice, and gave them ovariectomy. So this is a surgical menopause model. This was our first study, so we wanted to use this quicker model that does not take 3 months for them to go into menopause. And then did behavior testing on these mice afterwards. So this is just describing a little bit about the prodrug. One of the things I wanted to mention, so in this graph, you can probably barely see it, but the red dotted line is the changes in serum estrogen levels after you give this prodrug. And so you don't really see any changes. It's really the brain estrogen levels that spike. But you can also see that they clear out in about 2 hours. So when we're giving this drug, we decide to use elastic capsule implants, subcutaneous implants, so that we would have more of a continuous release instead of injecting it. And then the other question that I always get asked is, where in the brain does this conversion happen? And so they had done, the ProCry lab done this work to look at where it's actually being made. And lucky for us, 2 areas very important for learning and memory, cortex and hippocampus, are areas where there's a lot of conversion. So we wanted to look at this first in young mice. This was our first pilot study. So we overactimized them and gave them back this DHED or a vehicle treatment. And what we found in a spatial learning task where mice are in a kiddie pool of water and they're trying to swim to a little platform, that the mice were able to learn it faster when the platform was hidden if they received this estradiol prodrug. So they had an improvement in their spatial learning. Then 24 hours later, we gave them a test to see if they could remember where that platform would have been and how efficiently they would navigate toward it. And we saw a big improvement in their spatial memory. So this was exciting. It's enhancing spatial learning and memory in these young mice, but what's going to happen when we give it to middle-aged mice? So this time we did a longer study where we overactimized them, gave them back 3 different doses of the DHED. And then we did a couple of different memory tests about 3.5 months later. We also this time included an intact vehicle-treated, ovarian intact vehicle-treated mouse, just so there's a green line on the graphs, just so you can see what does a premenopausal mouse look like as a comparison. We don't see any differences with uterine weight, which is something that changes when you lose estrogen levels between any of our treatments, no changes of weight gain, glucose intolerance. And so overall, we didn't see any peripheral effects, which you would assume you wouldn't because it's a brain-specific prodrug, but we just wanted to check. However, we did see changes in memory. So when we did a working memory test, this is a Y maze where mice are supposed to basically go into an arm of a maze, then they go into a next one, they're trying to look for an escape route, but they wouldn't be going back to the one they just went to because then they would never remembered kind of, I've already been there. So if they have good working memory, they're gonna always keep like going around and checking for a new arm. And so the more alterations they have, the better. And we found both the medium and the high dose of this estrogen prodrug had an improvement. And then also in spatial memory, medium and high dose had an improvement. So overall, we found that this also, this estradiol prodrug had enhanced memory in these middle-aged mice. And so just overall, we found that menopause could worsen cognitive impairment in presence of other risk factors like vascular risk factors, and that this long-term brain-specific estrogen therapy could improve memory, at least in the surgical menopause model. We're now doing it in the accelerated ovarian failure model. And then we think it's exciting because our findings are really in line with the clinical data, which we've heard some about today, where menopause is associated with increased dementia risk. And it's also in line with some of the observational studies that have shown if you give hormone replacement therapy, at least if you initiate soon after menopause, it can lower dementia risk. That's it. Just wanted to say thank you to those in my lab and my collaborators.
Thank you so much, Kristen. That was amazing. Questions? Yeah, you're allowed, but we also have one in the back. So let's do back because I know that's a trainee and it's always nice.
Hi, your presentation was fantastic. I'm personally really interested in white matter hyperintensity, small vessel disease, and menopause. So I was wondering, have you been able to conduct the studies where you induce the menopause like naturally, but study their brain in response to the occlusion or well, like the partial occlusion through that process? Because often we study just before menopause, after menopause, and we really miss that transition point.
Oh, so like doing this
during that like 3 months.
Yeah, we have not, but we easily could because we can fairly carefully titrate kind of when they're going to be in that phase. So it's definitely something we could do, but we have not done it yet. Yeah.
Thank
that's a
you.
great question.
And actually, she has her PhD. Now I'm remembering.
Yeah.
Now I'm remembering. I was
You were
just an
there.
External examiner. Here you go.
Thank you very much. Excellent talk. I have two questions, if I'm allowed. So the first question is about this brain-specific estrogen. Sounds something amazing to use in humans. So where are we with this compound?
Yeah, so they actually recently patented just like last summer, and they are trying to move this forward. I'm hoping will be something that moves forward, but they're trying. The ProKai lab that developed it, yeah, they are.
And my second question is related to this model, which I really love because, you know, I think it's better than just doing overoctomy. But when I look at your data, weight data, it seemed like the weight gain was not as much as it was with overoctomy. How is the dynamics of the weight gain? Is that something that really is very profound change, or it just depends how much you weight?
I've never actually gone back in our data and directly compared them, but I could go back and do that we
Because
have
I
it from
think with
different
the
studies.
overoctomy, we got up to
Yeah.
40% weight gain, and it's pretty much all fat, to be honest with you.
Yeah.
So I really wonder, like, what's happening with this model, just because I think it's interesting. And
Yeah,
Yep, thank you.
I can get back to you on that for sure, because I could compare the data we have.
Thank
Thank
you so
you.
much, Kristen. Next up. As I'm introducing Dr. Gillian Einstein, I just want to say, Maria, that different models of menopause are okay because there's many menopauses. So OVEX versus, I know what you're saying, but we are going to hear about the many, oh no, please, Gillian, sorry. From Dr. Gillian Einstein, who's in the Department of Psychology at the University of Toronto, about we've heard about many menopauses, and now we're going to learn about the many menopauses.
Right. First of all, I just want to say thank you, Lisa, for inviting me to this conference. Really is a terrific conference and very impressive for your first year of your chair. So it's very cool. Yeah, I'm going to talk about the many menopauses and in particular, one type of menopause. And I have no conflicts, nothing to declare, sadly. Love it. So obviously you've heard now that menopause is a much studied as a turning point for women's cognition on the road to dementia. And I just want to emphasize that there are many menopauses. And the menopause I'm going to talk about today, after I talk about the many menopauses, is surgical menopause. And then highlight that with decrements in behavior and brain that we've seen in young women with surgical menopause. And then also tell you a little bit about how women experience these decrements. So a number of years ago, my lab actually wrote a paper called The Many Menopauses. We were interested in sorting out how the literature actually treated the term menopause. And NAMS and the Endocrine Society have guidelines to different kinds of menopauses. There's a spontaneous menopause, which is what I have over 50 years. There's early menopause between 40 to 45 years. There's premature, less than 40 years. And then there's induced, and induced can come from many sources. Perhaps the one that I focus on the most is oophorectomy or bilateral salpingo oophorectomy. And there are distinct hormonal changes with each one of these that lead up to and after menses cessation, so that each has a unique health and cognitive consequence. And I think it's really important to understand that. I think most people here do. And in fact, the previous talk was very helpful in that regard with the animal models. But I just like to go into it a little bit more. So we looked at papers in the literature in 2016. So that's a long time ago, and I'm hoping everything has changed. But we found, for the better, but we found some papers that gave absolutely no information on menopausal type or time since menopause, both of which are really important. And we called those undifferentiated. We then found papers that had some descriptive information in the methods, either reporting the age of menopause, the time since menopause, or the percentage of participants from each menopausal type. But these factors were not considered in the analysis. And we called that demographic differentiation. And then we had a category called partial differentiation, in which they maybe took time since menopause into consideration in the analysis, or type of menopause into the analysis, but not both. And then we had a kind of full differentiation, which reported on the different menopausal types and included those in the analysis, or studied only one menopausal type. So just to fill you in on what we found, and to show how clinical research lags behind the clinical guidelines, most of the papers we found in our the cut of the pie were actually undifferentiated, and the fewest papers we found were of the differentiated type. And you can see here when we divide up the studies, the 50 studies, into observational studies and clinical trials, that again, very few in each category were of the fully differentiated type. Most of them in each category were of the, let's just round up everybody who's 65 years and older, or says that they're in menopause, and let's just say they're in menopause. So those papers we found were the ones where there was a lot of controversy over hormone replacement, a lot of controversy over what the cognitive tasks were revealing. But what we found in the fully differentiated types were clear cognitive effects, including the detrimental effects of conjugated equine horse estrogens on memory, and memory changes at the menopausal transition, comparing pre, peri, and post. When taking these many menopauses into account, differences in memory and cognitive outcomes are actually seen for different types of menopause, and the outcomes are much clearer. So I don't think I need to say this to this audience, but it is really important to say the type of menopause that's considered. And even when you're reviewing the literature in your own papers, tell the reader what was done in the methods section. So we need to consider the type and the age of that type in order to allow for more rigorous cognitive research. We're studying induced menopause, and induced menopause, surgical menopause, the repercussions are immediate, as you saw in the lovely graph previously, where it's sort of like this, and then all of a sudden, boom, estradiol falls off. In studies that look within 2 to 6 months after surgery, the surgery is correlated with decreased verbal memory function, or verbal episodic memory, if hormones are not replaced within 3 months post-oophorectomy. And in the Sherwin study, she used 17-beta-estradiol. If you give exogenous 17-beta-estradiol, verbal word recall improves after 2 months of treatment. It's also in other studies correlated with, not E2, but the surgery is correlated with decreased verbal memory and a lot of other types of memory, as in this study here, which actually is quite interesting. It's a study out of Egypt by Farag and colleagues, and the participants in this study had an average education of 2 years. And so to some extent, I believe that this is one reason why we see such drastic effects here within 6 months post-oophorectomy. We don't see anything that drastic in our group, but we can talk about that later. And then the age of oophorectomy is correlated with increased all causes of death and dementia risk. An early study by Roca, who has gone on to show this over and over again. Any oophorectomy that's done before the age of 46 now, you can be pretty sure that those women have a much higher risk of Alzheimer's disease late in life. And a wonderful study by Riley Bove showed that with induced menopause, the earlier it occurs leads to a steeper slope of cognitive decline. So Riley basically recruited women around the age of 65, and then from there on, a longitudinal study from the Rush cohort, looked at the cognitive changes in global cognition. And the least steep slide is for spontaneous menopause, and the steepest one is for menopause before the age of, I think it's 38, which is now actually being recommended for women who have carry the breast cancer mutation, which puts them at high risk of breast and ovarian cancer. And a tour de force in Riley's study is that she got the brains at autopsy. And she found that in the women who had their ovaries removed prior to age 38, there was a higher plaque burden and a higher neurofibrillary tangle burden in the hippocampus. And Kajal Kantarshi imaged brains of women at the age of 63. They had their ovaries removed at 46. And she found smaller amygdala, smaller amygdala volume, thinner parahippocampal and entorhinal cortical volumes, entorhinal white matter, fractional I can't pronounce it, but you know what I mean, was lower. But there was no difference in the markers for p-tau, tau in the brain or plaques, no difference in cognition, behaviorally, and no effect of hormone therapy, but almost all of our participants were on conjugated equine horse estrogen. And in some studies looking at sleep post bilateral subpingual oophorectomy, they compared them to spontaneous menopause when women were at the age of 59 or 60, and they found worse sleep duration, worse sleep efficiency, that is, people took them longer to go to sleep, and more insomnia. So sleep is a player in cognitive problems, and you can see that it's a player here for BSO. So we wanted to know what happens in this vast period between 1 year, where we see the immediate effects, and late life, where most of the epidemiology has been done. And so we recruited women 1 to 13 years post-surgery. These were women who carried the breast cancer mutation. Their recommended prophylaxis, bilateral salpingo oophorectomy before the age of 40, so they fit in that risk category. 80%, this leads to some very beneficial results, which is an 80% reduction in the risk of dying from ovarian cancer, 56% reduction in the risk of dying from breast cancer, a 77% reduction in the risk of dying from any cause. And I haven't figured out how to square that with Walter's work. But it's prophylaxis in most cases. And what appealed to me at the beginning was that the women are healthy at the time of testing. They haven't had their ovaries removed because they have chronic pain. They haven't had their ovaries removed because they're depressed. They haven't had their, et cetera. However, I got very interested in the population as the population, and that's other studies that I won't talk about today. And this isn't a small population. In the US, 600,000 oophorectomies are done annually. And about 50% of them are bilateral subpingo oophorectomies. But I will say on the surgical front, things are getting better. People aren't just taking ovaries because it's easy when they do a hysterectomy, which is what they did about 10 years ago. So I think this is making its way into clinical practice. So we studied induced menopause due to the BRCA mutation. These were younger women with bilateral salpingo oophorectomy. Some of them were taking estradiol therapy, and some of them were not. They were recruited 1 to 10 years post-oophorectomy, and each woman has been tested between 1 to 3 years. But all the data I'm going to show, every 3 years. But the data I'm going to show you are just from time point 1 right now. And we've focused on spatial working memory and verbal episodic memory. So the few previous talks are perfect introduction to this. And obviously we're all focusing on those because those are considered to be some of the earliest behavioral signs of dementia and Alzheimer's disease. We did imaging, MRI imaging. And we've done a lot of other measures that I'm not going to talk about today, but I'm also going to tell you about some qualitative interviews that we did and something called body mapping storytelling. So these are just the recruitment parameters. And I think the most important thing here is that inclusion was 35 to 50 years of age, because we really just wanted to stay away from when we recruited our age match controls, we wanted to stay away from perimenopause, and we also wanted to stay away from drastic changes with aging, cognitive changes with aging. Most women were prior to the age of 49, and all of them had the BRCA mutation except for our age-matched controls. We excluded people that within 6 months had chemotherapy or any kind of adjuvant treatment. We didn't include people with untreated depression or any kind of untreated metabolic disorders. And our age-matched controls weren't taking any birth control and our spontaneously menopausal women, who we ultimately did also recruit, weren't taking hormone therapy. So it's a big cohort, and we had many recruitment sites. So just to give you an idea on one demographic outlay, the ages were on the average, around 44 years of age. At the time of testing, the education was high. BMI was quite reasonable. Age at BSO for the women with BSO was, 38 for the women taking estradiol therapy, and 42.5 years for women not taking hormone therapy. Time since BSO was on average 5 years. There were some with a history of chemotherapy and more in the group that wasn't taking hormone therapy, because hormone therapy is counterindicated if you have had cancer. You can see there, none of them scored high on, at least at the time of testing, on mood, poor mood, and all of them did the same on the North American Adult Reading Test. So the first thing we showed was that BSO reduces 17-beta estradiol and progesterone levels, and you can see that here. But in the women who were taking estradiol therapy, you can see that their levels were roughly as high as the AMCs. Progesterone was all over the map, which is interesting to me, in the women who were taking estradiol therapy. They were all, we call it therapy because they were also, wasn't unopposed, but the progesterone therapy just differed crazily. On logical memory, paragraph recall, verbal episodic memory, you can see here that for the immediate recall, both the women with BSO taking estradiol therapy and the women not taking estradiol therapy did worse than the age-matched controls. So estradiol therapy here didn't seem to do a lot for our group. For spatial working memory, there was a digit span backwards and also a spatial working memory task, Elizabeth Hampson's wonderful task. It looks like just the women not taking hormone therapy did worse. So just the BSO, no estradiol therapy, did worse. Estradiol therapy seemed to really help with this task. And as some of you may know, at least Elizabeth has shown that spatial working memory in young women varies with the menstrual cycle, and so estradiol levels. When Nicole Gervais looked at the hippocampus and she did high resolution T2 scans and then did manual segmentation. When she looked at the medial temporal lobe altogether, she didn't see any differences between the groups. But when she looked at just the dorsal, the dentate gyrus CA2-3 region, she did see a difference between the women with BSO and the age-matched controls, and the age-matched controls and the women with BSO taking estradiol therapy looked pretty similar. So estradiol therapy seemed to be pretty good here. Alana Brown did functional imaging using essentially a Sperling face name task. And you've already learned what an associative task is like from Natasha. And what she found was that The associative memory, novel versus repeat pairs encoding, the difference was actually between the age-matched controls and the spontaneously menopausal women. So the women with BSO didn't do significantly worse than the age-matched controls on the encoding, novel versus repeat. But the activation for novel versus repeat pairs encoding did differ. And in this case, the women with BSO strongly resembled the women in spontaneous menopause, and both of them did worse than the women with BSO taking estradiol therapy. So estradiol therapy, whoops, I didn't see that. Whoops, okay, 3 minutes. The women taking estradiol therapy are maintaining their own here. So we decided to ask women, what is this experience like? And we asked them, are you having any problems remembering things or concentrating? Really in a way to get at what the experience is like for them, but also to get more deeply into whether or not they might have what we would call subjective cognitive decline. And one woman said, I started noticing memory problems. The issue is primarily the speed of recall. I can eventually remember the name that I'm searching for. It just seems to take far more time. And she goes on with lags of names, etc. Post BSO, I started noticing I no longer remembered conversations, people's names, etc. It took a lot of effort to recall where I had placed things, if not in their normal spot. So all of these things are really commensurate with verbal episodic memory and spatial working memory. And this is an interesting example, I think, of where the memory complaints map on to the objective scoring. So one of the things I like to do is what I call very mixed methods, where I add both qualitative, quantitative, and a physiological measure. And here, if we just compare, I don't even know if you can read this, but if we compare what the women themselves said, what they said when they were just asked on a demographics questionnaire, are you having memory problems? And then their scores compared to the mean for the norm, you see that almost everybody's having verbal episodic memory problems. 1 or 2 people have very low scores for spatial working memory. And it just maps onto what they're saying. Although you'll also notice in the 3rd column over, when we asked them, are you having memory problems? A number of them said no. So it really does behoove us to ask people in more detail, what is it like for you? Then we've done something that's been really a lot of fun called body mapping storytelling of some of the same women. And basically we supply them with art materials and they lay down on a big sheet of paper. We trace the outline of their body and we ask them to put on their body their memory. Where was their memory located on their body? I had all kinds of crazy hypotheses that probably didn't bear any fruit. But one of the interesting things is that when we asked them to tell us the story of their body map, we found 2 themes that really mapped onto memory problems: chaos around the head and memory tools that they all used. So let me show you some of those. For chaos around the head, you can see here that this woman has got all these streamers coming out from her brain and kind of a mishmash of things in her brain. And in her story, she actually described it as chaos around the head. Here, this woman has a kind of mishmash in her brain. And here, the hair is flying out. There's lots of stuff coming off from the top of the head. And I think these are pretty nice depictions. And you see the same depictions actually in the next view on the memory tools, but you also see these memory tools. So this amazing woman actually gave us the diary that she kept of the year when she had her oophorectomy, and no time, whoops. This woman here, you can see these are all diaries that she keeps. She has a diary for trips. She has a diary for things that happened during the day. She has all kinds of diaries. It's incredible. And one interesting well, I'll tell you this story later. I don't have time. And the same here is just of, she's got her to-do list. She's got her barbells for exercise. This woman has her healthy eating, raspberries, etc. So I just want to end saying, with the acknowledgement of a lot of individual differences within each category of menopause, all menopauses are not created equal. BSO prior to spontaneous menopause may be the riskiest with respect to late life AD. I could go through all this again, but I won't because I have 0 minutes. But I think I want to get down to this last point here. They are told that they are in menopause, that they will have menopausal symptoms, but this is not spontaneous menopause for them. They tell us they don't know what to do with it because it's not like what their mother went through. And it's just not menopause as they think of it in terms of their symptoms and their risk for AD. So different menopauses have different cognitive, brain, and experiential effects. And I just want to end with keep your ovaries if you possibly can. So I want to thank my students and collaborators and funders and you for your time. And
Wonderful as always, Jill. We have time for one question. I know you want way more, but you get one. So, okay.
Thank you so much, Dr. Einstein, for that presentation. I wanted to ask how the literature sort of views hysterectomies and oophorectomies. Like, does it conflate the two? Are the effects the same? Or is it different? Because anecdotally, I know my mom's had a thyroidectomy and a hysterectomy. So I'm just connecting the dots between like all the cognitive symptoms and wondering if it's like similar effects for oophorectomies versus hysterectomies.
okay, thank you. I asked Lisa to repeat the questions because this room eats sound for me. Can you repeat it?
Yeah, she's asking about.
So
I
everybody-
think what you're saying or asking is, does the literature conflate hysterectomies and oophorectomies
Oh.
in terms of memory and brain?
Yeah, that's a really great question. And it's very interesting. Up until now, certainly in databases collecting information about XX people, let's just say, and reproductive histories, hysterectomy and oophorectomy are often conflated. A lot of times women don't even know whether they've had an oophorectomy. And in the age at which people are being recruited for dementia studies, they may not even have known whether they, whether their ovaries were taken at the same time as their uteruses. However, there are some recent UK Biobank papers looking at hysterectomy and oophorectomy separately. And while I don't think the hysterectomy data actually clarify whether they also had an oophorectomy, there does in those studies seem to be a risk of hysterectomy. And maybe adding to the issue is there's some animal models showing actually the hysterectomy alone is a bit of a risk for cognition. And in the BRCA literature, hysterectomy without oophorectomy is more protective. Hysterectomy with oophorectomy is more protective than oophorectomy alone from cancer. So I think the evidence is beginning to be gathered, but there isn't enough separation in the literature, as you very wisely pointed out. Yeah, thank you.
Thank you so much, Jill.
You're welcome.
Next, last but not least in this symposia, please stay for the Young Investigator Symposia. They'll be quick, right? Three minutes, and they'll be amazing. Is Dr. Cindy Barha, who is a newly recruited assistant professor in kinesiology at University of Calgary. And I'm resisting the urge to say that she did her PhD with someone special.
Don't worry, it'll come up. It'll come up. So I wanted to thank Lisa for inviting me. I feel
so privileged and honored to be here sharing the stage with giants in this field. It's really amazing. So I'm going to talk about sex differences in the beneficial effects of exercise on cognition in older age. So the data I'm going to present was mainly collected during my postdoc at the University of British Columbia in beautiful Vancouver. So last year I traded in these beautiful, warm, green mountains for the cold, snowy mountains of Calgary. And it was snowing yesterday when I left, like, honestly. So I joined Calgary in the Faculty of Kinesiology as a neuroscientist. And so this has already been set up really nicely for me. Dementia is a global health issue. So worldwide, 1 new case of dementia is diagnosed every 3 seconds. So, and 1 in 3 seniors actually dies with Alzheimer's disease or related dementia. So that's more than breast cancer and prostate cancer combined. So I'm not going to go into this because I know I'm going to go over time. And also already set up nicely for me, females do really seem to be at the center of this disease. So 2/3 of all people with Alzheimer's disease are females, and they also have a greater lifetime risk of Alzheimer's disease, which is partly related to their 4.5-year longer lifespan. Females also show greater cognitive decline after they've been diagnosed. And in both humans and rodents, females show greater neuropathology related to Alzheimer's disease. So that includes hippocampal atrophy, as well as greater amyloid and tau deposition. Also talked about this previously, non-modifiable risk factors associated with Alzheimer's show a sex difference and may have a greater impact in one sex. So for example, the ApoE4 gene variant, the greatest genetic risk factor for Alzheimer's, seems to have a greater impact in females compared to males for some outcomes. The BDNF Val66 MET polymorphism, which I'll talk a little bit more about later in my talk, also seems to show the sex difference and seems to be more related to dementia risk in females. Other risk factors for dementia are actually specific to one sex. And so Dr. Einstein did an amazing job talking about surgical menopause and natural menopause. So I want to also add in pregnancy history may also be a sex-specific risk factor for dementia found in females. And so my new lab, what we want to do is learn and understand what sets up the female brain for cognitive impairment and for dementia, and then determine how we can best use exercise to promote brain health. And so a very quick note about the vocabulary that I'm using today. So I've been speaking about sex differences because we're looking at sex assigned at birth in our participants. But I do want to acknowledge that we haven't disentangled the influence of gender in our research. And most likely it's going to be both sex and gender that are influencing our results. Okay, so as I said, I focus on exercise as an intervention for brain health. Something's about to restart. Oh, no.
Let's just press X.
Okay, okay, we have 15 minutes, go.
Huh? Just go, okay. I don't think it's gonna let me. Okay, so I focus on exercise, where is I? Something, exercise. So I focus on exercise as intervention for brain health because it's one of the main modifiable risk factors for dementia. So non-modifiable risk factors have been identified and they account for about 60% of dementia cases worldwide. But I'm talking really fast now. 40% of cases have been attributed to 12 identified modifiable risk factors. So that includes things like smoking and diabetes and hypertension. And importantly for me, physical and okay, it does work. Physical inactivity is one of these modifiable risk factors. And more importantly for me, it seems to potentially show this sex difference. It may be more important for one of the sexes. So for example, I love this study, some really great work published a few years ago in 2021 out of Finland using combined data from 3 Nordic population-based cohort studies actually suggested that physical inactivity was a stronger risk factor for dementia in females and maybe not in males. And so this table that's from that study, you can see down here in females that have marked in red, the association between physical activity and dementia risk was significant in females. And so higher levels of physical activity were associated with reduced risk for dementia. In males, though, that association between physical activity and dementia risk wasn't significant. I do want to draw your attention to this last column. So there's a significant interaction here. So this shows us that the association between physical activity and dementia risk was significantly different between males and females. And I think it's really remarkable that it's the only risk factor of all the different ones they looked at that shows this significant interaction. And so to me, this really suggests that physical activity may be a stronger risk factor for dementia in females. And so potentially, if we increase levels of physical activity in females, it might be more important for cognitive function. And so importantly, right now, there's currently isn't an effective pharmaceutical approach that works across all subgroups of people, not just white males, that is for cognitive impairment. But physical exercise really does seem to show some really promising results in terms of prevention and maybe even treatment of cognitive impairment. And so engaging in aerobic exercise interventions really does potentially seem to be beneficial for cognitive function. And I think you can see that fairly nicely in this seminal review paper by Stanley Comey and Art Kramer. These are giants in the field of exercise and neuroscience. They kind of got everything going. And so exercise, which is in the white bars in this graph, is associated with benefits to several different cognitive domains compared to controls, which are these gray bars. And in this particular meta-analysis, the greatest beneficial effects of exercise were actually for the domain of executive functions. So very briefly, if you've never heard of that before, these are sort of higher order processes that enable and sort of drive adaptive and goal-oriented behaviors. Okay, so despite all these really great results that I just talked about, there is still a lot of variation found in exercise efficacy for cognition, because not all studies actually find these beneficial effects. So one of the best examples of this is the LIFE trial. So this is the longest, largest exercise randomized control trial that's ever been conducted, with over 1,600 older, cognitively unimpaired adults. And they found that a 2-year, very long exercise trial, 2-year multimodal exercise intervention actually didn't have any benefits to cognitive function across all these different domains. So it didn't have an effect on hippocampal dependent learning memory tasks, or even on those executive function tasks. And this was in comparison to a health education control group. It also didn't alter the incidence of dementia. And last year, there's a somewhat controversial umbrella review of meta-analyses of randomized control trial of exercise. And so this umbrella review actually suggested that the beneficial effect of exercise on cognition may not actually be as large, might not be as strong as we've previously thought. So right now, the goal for exercise neuroscience as a field is really to enable these precise evidence-based recommendations for brain health. Okay, it's doing it again. Okay, so we envision being able to understand this by looking at the variation, the sources of that variation that we're seeing in trial outcomes. And so we can do this by looking at the what, the who, the how, and the when of exercise. So what type of exercise is most beneficial for cognition? So aerobic exercise, resistance training, Tai Chi, yoga. And we can also look at for whom these different types of exercise paradigms are most effective. So this includes looking at sex differences, looking at specific genotypes, as well as looking at the cognitive status of individuals. So whether they're cognitively unimpaired, if they have mild cognitive impairment, or even a specific type of dementia. We can also look at how these different types of exercise paradigms are exerting their influence on the brain. And I've listed a few different outcomes that we look at. And also, last but not least, we can also look at when exercise is most beneficial for the brain. So for example, we can look at midlife versus older age. And so today I'm going to talk a little bit about the who as well as a bit of the how of the work that I've done by asking, do sex differences exist in effective exercise on cognition? And so I've been able to directly examine the interaction between aerobic exercise and biological sex by conducting a sex differences analysis of a completed randomized control trial that was done by Dr. Teresa Lou Ambrose at UBC, where I was a postdoc. So this is a 6-month randomized control trial with older adults with mild vascular cognitive impairment. And so half the participants received a 3 times per week moderate paced walking program, and the other half were in the control group, and they received usual care and educational material. And so the primary findings from the main paper did show that the aerobic training paradigm improved episodic memory performance and also reduced blood pressure at trial completion versus the controls. But for my sex differences analysis, I actually focused on executive functions because I had previously published a meta-analysis that had sort of pinpointed that cognitive domain for sex differences. And so this graph here is showing change in performance on the trail making test, which measures set shifting, one of the main components of executive functions. So here, negative change scores actually indicate an improvement in performance from baseline. And you can see that in our females, aerobic training significantly improved performance in set shifting compared to controls. And in our males, the aerobic training control groups actually didn't differ from each other. So when we looked at cardiovascular fitness to assess the effectiveness of our aerobic training paradigm, we actually found that although the males didn't see that benefit to executive functioning from aerobic training, they saw these really, really nice improvements in cardiovascular fitness. So functional fitness capacity, as we call it, because we use a 6-minute walk test. And it's really surprisingly, we didn't see this at all in our females. So very intriguing, considering this very main hypothesis that we have in the field that aerobic training influences cognition through improvements in cardiovascular fitness. So if it's not cardiovascular fitness, then what could it possibly be? So to begin to look at how aerobic training might be influencing cognition differently in males versus females, I looked at the effect of aerobic training on brain-derived neurotrophic factor, or BDNF. And so previous studies, mainly in rodents and a little bit in humans, does suggest that BDNF is one of the mediators of aerobic training effects on the brain, but it's never been, sex differences have never been looked at in that context. And so I found that at trial completion, aerobic training increased BDNF levels to a greater extent in our females than our males. I got 6 minutes. Okay, so we know that aerobic training leads to greater gains in executive functions in older postmenopausal females compared to older males. And this might be related to aerobic training having greater effects on BDNF levels. So to further look at sex differences in this relationship between aerobic training and BDNF, we took advantage of a naturally occurring polymorphism within the gene that codes for BDNF, the Val66 MET polymorphism, to look at how it could be interacting with biological sex to sort of further moderate aerobic training effects on cognition. And so very briefly, the Val66 MET polymorphism within that BDNF gene is present in about 20 to 50% of the population, based depending on your ethnicity. So carriers of the polymorphism, so people with the MET allele, show altered intracellular trafficking of the mature form of BDNF compared to Val carriers. Some studies in humans do show that the MET allele is associated with smaller hippocampal volume, as well as altered or reduced cognition. But of course, not all studies find this. So one potential reason for these discrepant findings that I personally find interesting is potential sex differences in this relationship between BDNF and the brain. And so, for example, in both humans and rodents, increases in estradiol lead to increases in BDNF. As well, in humans, females actually show higher BDNF content in specific brain regions, including the prefrontal cortex, which subserves executive functions. And we've previously shown that there's an interaction between the polymorphism and biological sex for cognitive decline over age in older humans. And so we wondered whether biological sex could be interacting with the BDNF polymorphism to further moderate exercise effects on cognition. And so we ran another secondary analysis of our exercise randomized control trial to look at this interactive effect of biological sex, BDNF genotypes, so whether they're Val carriers or MET carriers, and experimental groups. So in this case, whether they had undergone aerobic training or if they were in the control group. And we looked at this effect on 3 different tests of executive functions. And so we found a significant 3-way interaction between sex, the polymorphism, and experimental group for 2 of those 3 tests of executive functions that we looked at. So first, the results for the trail making test. So that's that set shifting task. So here, this time, higher numbers actually mean worse performance, and aerobic training is in gray and controls are in black. And we actually found that in aerobic training, improved performance on set shifting compared to controls, but only in our female Val carriers. And if anything, it actually decreased performance in our male Val carriers. And it was not effective in males or females if they had the polymorphism, if they had that MET allele. The other test we found this significant 3-way interaction for was a digit symbol substitution test. So this one looks at processing speed, sustained attention, and working memory. And so now higher numbers actually mean better performance. And we found once again that only in our female Val carriers, aerobic training improved performance compared to controls. And if anything now, the aerobic training was actually reducing performance in our female Met carriers. And in our males, no effect of aerobic training, regardless of genotype. Okay, so in addition, this is my favorite part, so I really want to get to it. So in addition to sex differences, I'm also really interested in looking at how cognitive status of individuals can actually moderate the efficacy of exercise to improve brain health. So I was really wondering if that beneficial effect of exercise that I see in our female participants could be actually related to a previous reproductive experience. Several reasons for this, but the one I chose to talk about quickly is the fact that there's emerging evidence that previous parity, so number of previous pregnancies, actually can alter your risk for dementia in older age. So it influences your cognitive status in older age. Okay, so we know pregnancy has profound effects on female physiology, brain function, and disease risk in both the short and long term. So I'm not going to go into this figure at all because I think we're going to address this tomorrow. And also I have 2 minutes. So I'm going to go to the long-term changes here. So we don't know very much about how pregnancy influences changes in the brain in the long term. But there are some studies that suggest that having high parity, so having 5 or more complete pregnancies, can actually increase your risk for dementia. As well, having had being nulliparous, so having 0 pregnancies previously, can also potentially increase your risk for dementia. Okay, so to see whether previous parity alters a relationship between physical activity and cognitive aging, I utilized data from a 10-year longitudinal epidemiological cohort study. So this was, in this study, they recruited about 2,900 older adults from Memphis and Pittsburgh in the US. These are well-functioning, community-dwelling older adults. So they're cognitively unimpaired at baseline. And so not a big part of the study, very, very small part of the study. They did look at physical activity levels using self-reported time spent walking. So this is minutes per week. And this was assessed every year from years 1 to 10 of the study. And so using that measure, for these analysis, I looked at average amount of physical activity. Also not a main part of this study, they looked at executive functioning using that digit symbol substitution test, as well as global cognition using the 3MS, the Modified Mini Mental State Exam. And they gave these tests at different times in that 10-year study period. So we were able to look at individual trajectories of change in cognitive performance on both those tests. And also we were able to look at average performance on those 2 tests. So then we took the total parity. So this is the total number of complete pregnancies that the females underwent. And we grouped them into 4 different groups based on previous literature. So we have a nulliparous group, so 0 complete pregnancies, a low parity group, 1 to 2, medium parity group, and then we finally have our grand multi-parity group. So this is 5 or more complete pregnancies. Uh-oh, it's happening. It's at 0.
I'm supposed to vamp until this is a feature of the CAMH computer. They just reset. But there's another one coming. Can you make sure it's coming? It was supposed to come in 1 minute. You can tell the story, but I don't know if I guess the Zoom people are still up.
It's working on updates right now, so.
It's working on updates. Oh,
Oh, we have another one.
Do you have her presentation up? I didn't have to vamp for very long, and I'm very sorry. We do apologize. We did have backup computers, but they all reset at the same time.
What was it?
I was gonna be. Anyway, whoa. Does anybody have a question for Cindy at this point? So we can do a couple of questions while we're waiting. Kristen. Okay, Cindy, how do you feel about answering questions while you're getting a presentation up?
Super interesting talk. I'm wondering, because some of the work you showed was in VCID and vascular dementia, do you think you would see different effects of the exercise and the BDNF in Alzheimer's disease versus VCID, or have you looked at that at all?
So that's a great question. Wait, and while you're talking, I would have presented. I'm trying to find my. I don't have it, so that's good. So in other I didn't talk about it, but I have seen the same sex difference in other populations. So cognitively unimpaired adults. So we have an epidemiology study that like data that we used, and we found the same sort of sex difference. We also have looked at it in cognitively healthy MCI and also mild cognitive impairment population. But we haven't been able to look at this in Alzheimer's disease. So we did do a meta-analysis and looking at different types of exercise interventions in Alzheimer's disease trials. And if anything, there seemed to be the opposite sex difference. So this is something I think is really interesting. And I want to follow up, and I'm trying to get my hands on data for exercise in an Alzheimer's disease population that's large enough, like a large enough sample, but I haven't been able to do that yet. But it's, if anything, it looks like it might be the opposite. So that would be really cool. We are actually finishing up two large studies at UBC. One is looking at comparing resistance training to aerobic training using it's a factorial design. And so we'll be able to, that's mild cognitive impairment. So we'll be able to look at that population as well. But yeah, it would be really, really neat. Sorry. Oh, I still need my notes. So I don't know. I don't think I have it. No, I don't have it. Nope. So do you want to just, I can just talk about my results. How about that? Okay, so this is my favorite stuff. I've never got to, I don't even know if I've ever really got to present it. It was published last year. So what we found was that so we looked at the relationship between average physical activity and then performance on the two tasks. And we looked at change in performance over time. So how much decline over 10 years, also just average performance on those tests over that 10 years. And then you don't want to know the stats, they're boring. So what we found was that the relationship between average physical activity and performance on both tests, so executive functioning or global cognition, was only significant in the nulliparous females, so the females that had 0 complete pregnancies, or the grand multiparous group, so the females that had 5 or more pregnancies. And that was the same for average physical activity and average performance. And when we looked at average physical activity and change in performance on those two tests, it was only significant in the grand multiparous group. So it does seem potentially that the relationship, the association between physical activity and cognition was only seen in the groups that are most at risk for cognitive impairment and dementia. So previously, as I kind of mentioned, the grand multiparous group has been shown to have an increased risk for dementia. And this is where I was going to put up some old data of ours. So we've, Dr. Lisa Glee and I have previously shown that in rodents, nulliparous rodents actually show reduced cognition in older age. And they also show lower levels of hippocampal neurogenesis in older age. So they could be also considered an at-risk group. And so potentially, and this is something I want to look at now in my own lab, is maybe exercise is going to be more beneficial for these two at-risk groups. And then my conclusion was that we really should consider biological sex and genotype and reproductive history when we consider different interventions for brain health. The end. And I think we have time for a couple of questions. One question.
There was a study that just came out, and I'm wondering with your ABCD study too. I'm not on there. It says that Lisa Glee is on there. I'm not on there. That said that physical activity was more beneficial for females compared to males, so women compared to men. But one of the authors of the study made the point, and they make the point in the limitations, that this was retrospective data. And so a woman claiming that they did 150 minutes of activity a week might have been underestimating because they did more, sorry to be so gendered, but do more housework and do more, picking up of the grandkids or the groceries or whatever it might be. So do you think the same kind of, like when we think of physical activity and the way that they're measuring it in some of these large databases, are we underestimating the amount of physical activity that women are doing?
That's a great point, and absolutely, I do think so. In fact, there's some research that suggests that males overestimate how much physical activity they do. So kind of interesting. I didn't put it up there, but well, I shouldn't put it up at all, but in my graphs, I also usually put in, so I put the 4 parity groups up there with the association between average physical activity and the cognition. And then I put the male association between physical activity and those cognitive functions. And there's no, in that study, there's no association in males either. So absolutely, I think, and so there's other studies out there that we'd like to, other data out there we'd like to look at, because you're absolutely right. So if we look at different ways of measuring physical activity, it might give us different ways of looking at it. And so I do have access to a really cool study in the States that looks at quantitative physical activity in a cohort study, in a long-term cohort study. They've strapped on like an Apple Watch basically on their participants and then measured physical activity levels in males and females for over 10 years. And so that'll be really interesting to look at, because, and they also have retrospective questionnaires as well. So we can compare the two. So that'll be really neat. I don't know if I should say this. I'm also going to get the postmortem brain so I can look at neurogenesis in them. Oh yeah, and I got a grant for it, so I'm super excited.
I just have to say, what a trooper. Can we just give her a second?
Mentors and my co-investigators, at least is now on my co-investigator list, the trainees that helped, funding, subjects, and then this is what I wanted to put up. So I am actively looking for grad students and postdocs, and I will say, Calgary, it does snow, but it's a really exciting time to actually be at this university, especially in the Faculty of Kinesiology. We just got this really large $30 million endowment for women and girls research in kinesiology. And yeah, it's right before I got, or right after I got hired, so coincidental. And we also, so there's a group of us in kinesiology, other females, and we've created this group, this collaborative, to look at menopause and movement, and we're just going to start this large cohort study in Calgary to follow women across the menopause transition, to look at movement. And I want to bring in brain health, and we just got a $1 million internal grant from this endowment to do that. So it is a very exciting time to be there for women's health.